Okay, so welcome to adults. This is a much more informal session, much less didactic than the last. And actually, most of the ones I've done of late have been remote rather than a face-to-face. So we've got a variety of experts. I know it says Dr. Cooter and I, but I just wanted, I think everyone's spoken, so we probably don't need to do introductions, but I can bob around and bring microphones to everybody, any questions. It's slightly daunting to ask in a big room. But I was going to start by saying, are there any topics that people want to cover that either have been covered this morning and created a level of confusion, or topics that maybe you'd want to expand on or a little bit more detail? And I will come with my microphone, like Michael McIntyre does on his show. I'm going to put it under your nose and ask you what you want.
Well, I want to ask something which isn't anything probably to do very much with what's been covered, but I want to know why the Department of Health have decided that people who've had a splenectomy don't need extra vaccine, and why they've downgraded the immune problems that people might have with splenectomy.
Drew.
No, I think this is a splenectomy expert here.
Dave, who wants to answer this?
Well, I'll be honest, I think that splenectomy creates not a huge immunodeficient problem like you have in a transplant patient or someone who's on chronic immunosuppression. So I think it's a distinct immune deficiency for the spleen. It's a distinct immune deficiency with the spleen being the major site for maybe 3 or 4 bacteria that are commonly cause trouble. So if you're appropriately vaccinated, you have a significant amount of protection from having those what's called overwhelming bacterial sepsis. So it's usually bacteria that give you troubles if you have no spleen. You handle viral infections normally, unless you get a super infectious bacteria. So I don't regard most splenectomized patients as being that immune deficient. They have a distinct immune deficiency. You should all be carrying antibiotics. You should know what to do when your temperature goes to 101. You should be appropriately vaccinated every 5 to 7 years, depending upon national guidelines, which differ here versus the United States.
And we don't escalate vaccine programs for other viruses in patients who've had a splenectomy. Lost my microphone again. We don't escalate other viral vaccine programs for patients who've had a splenectomy. It really is, as Dave says, it's the bacterial ones. Yeah. And we did a snapshot audit of our ITP patients at the London for 2 reasons. Number one, to try and look at, for our group, which patients got more sick with COVID, as in hospitalised, etc., and also any particular treatments that were associated with that. And almost universally, the patients for us that ended up really sick with ITP were on the kind of non-rituximab immunomodulatory therapy, mycophenolate, azathioprine, cyclosporin, sirolimus, all of those types of medicines. Dave?
Yeah, I think that, to be honest with you, the thing that asplenic patients, people with no spleen, ought to recognize is that they ought to be up to date on vaccinations. I don't know what the British guidelines are, but in the United States, it's a Haemophilus influenza vaccine once at the time of your splenectomy or soon thereafter. Number 2, a pneumococcal vaccine of 2 types until you're 65, after which there's no recommendation for any further vaccinations, and a meningitis of both types with follow-up every 5 years thereafter. So I think that it's probably close to what you have here, but if you follow those vaccination criteria, you have pretty good reliability that things are not going to go bad. I think all asplenic patients ought to have some penicillin around, or whatever your current recommendations are for bacterial prophylaxis. And obviously, if your temperature goes over 101 and you got the shakes, you should be in the emergency room within 20 minutes. So those are things, but to be honest, it's a very rare patient. And the good thing, if any of the Aussies here, I mean, there's the Spleen Society. You've got this lovely organization, I think, in much of Australia, where all patients with no spleens are registered. Yeah.
Yeah, there's a spleen registry, and you can register with Spleen Australia if you haven't got a spleen, and they remind you so often that, vaccines and, what to do if something's wrong, and carry a little card and so forth, yeah. So that's certainly the Australian point of view.
That's fantastic, actually.
Thank you. Well, hello. First, I'll say I have really enjoyed meeting everyone for the first time today to meet anyone with ITP, and it's been such a pleasure to. Anyway, I just wanted to back up some of the things that you doctors have told us today, but just coming from me, the patient, that it still is very much a number game, I think, and your doctor, your consultant, whoever, is looking at what are the platelets. Are they 10, 20, 30? And in my position, it's always been, let us wait until you are around 20 before anything is done. And I know quite a lot of people suffer with fatigue. This is very hard to cope with, because this is the probably, other than the spots, the blood tests, the nosebleeds, etc., you can cope mostly with this, but the fatigue affects your whole life and how you have to cope with it to have more normal type of life. I have talking to people today who is suffering with real fatigue, and I would prefer to have treatment more early, when my levels, for example, would be 50, not wait for until 20 or lower, because I'm feeling a bit brighter at 50. When I am getting to 20, 10, etc., I'm feeling like dragging along the pavement because no energy. So just to back up your more your most recent thoughts is maybe sooner is better, just to say. And I'm sure other people is thinking.
Excellent point, and thank you, and great to have you here. You were saying this when we were talking earlier, this is your first one. So I'm going to hand over to Drew first on that one, because you were a co-author on IWish study.
I was. Those are good points. And when I was speaking, I was saying that we were trying to move away from being fixated on platelet counts, and because the platelet count tells you so much, but try and move back towards symptoms and how you feel. And we try to treat people as individuals. So some patients, like fatigue, their fatigue disappears when their platelet count goes up a bit. Other patients we can treat and their platelets reach a good number, but yet they're still incredibly drained. So one does not solve the other sometimes, which is what you find. And again, your treatment should depend on how you feel at that time. And you're not, we don't use one formula for everyone. So for you, you may need a platelet count slightly above to have a normal life, whereas someone else will be fine with a platelet count of 30. It's a very complex issue. The whole fatigue, we don't even understand why people are tired, quite honestly. And Dave, you might want to. I know everyone has to be taken on his or her own merits and treated depending on what they have at the time. Rather say everyone above a certain count needs no treatment, everyone below a certain count needs treatment, etc. It's very hard to be so prescriptive about treatment with this disease, where the goalpost is very vague and our concepts aren't quite as crystal clear as, say, breast cancer, lung cancer, hypertension, lots of other diseases. This is very great, so many great areas in ITP. I'll let Dave take over.
Yeah, I think right now, first of all, 80% of patients going to doctors complain of fatigue. That's the number one complaint of doctors at any disease, cardiac, oncologic, hematologic. Number two, ITP patients have a higher degree of fatigue in my experience in the studies than other people, no ITP. Thirdly, some patients improve when you raise the platelet count. Other patients, I've normalized the platelet count in many patients with agents, and they don't feel any better. I think that the point you should be making is that it may pay in any one patient where fatigue is a big issue to ask whether the platelet count's a problem or not, and give you a trial of a higher platelet count for a while to see if that makes you feel better. Half the time it works in my experience, half the time it doesn't, and there's other causes for fatigue that we have to recognize.
But to bring John in, if you look at other autoimmune diseases, primary biliary cirrhosis, they've looked at fatigue in that, and again, it's a big feature of that disease when the disease is active. And John can maybe tell us why some people might have fatigue when they're ITP is active? And also, John, why do some people still feel fatigue maybe when their ITP is quiet, perhaps? I don't know. I'm sorry, it's a big ask, I know.
I don't know.
Okay, next question.
It's really interesting that, like David says, ITP patients seem to have a lot of fatigue, and for a relatively benign disorder. I mean, the only thing that I've ever thought about is that platelets contain about 10% of our serotonin. And serotonin is one of the happy neurotransmitters, and it does pick you up. Now, I don't know if that's the case, because the other thing is serotonin doesn't cross the blood-brain barrier. So it might be something along those lines, that it's this neurotransmitter is missing in patients. I do know that in mice, at least the mice that we work with, if you make them thrombocytopenic, they do get lethargic. Now, I don't know if that's fatigue, but it's certainly they're not as active as they are with a normal platelet count. They they become more sedentary. So, there is something to it, but I really don't know what the mechanism is.
Is it tied to inflammation?
Yeah, I think so. In inflammatory disorders, like Dave says, there's a lot of fatigue that goes on. Inflammation takes a lot of energy, and that alone can cause a lot of fatigue.
I think there's one other element, if I may mention, which is that there's another disease which is called cold agglutinin disease, where antibodies attack red cells and make your red cells disappear, and that's mediated by the substance I mentioned briefly called complement. And many autoimmune patients have a high complement level, which have low complement levels because it's being activated and released. And what's interesting is if you block complement in many diseases, the fatigue disappears, but the thing that causes the disease doesn't change. So sometimes we give people things to make their red cell count get better. It doesn't affect their red cell count, but patients feel much better on these drugs called complement inhibitors. So I think that there may be a role when we have better grasp of complement.
So yes, I think it's a complex issue, isn't it? And I think you were talking about a count of 20. I suppose we've evolved our management. So that kind of historical, and 20 probably is the cutoff where we're seeing more bleeding problems in patients. So as a number to start to say, right, well, as a safety net, really 20 is where we think. And then as Drew said, above 20, there is a sliding scale. And your platelet count threshold that we would be aiming for also changes throughout the course of your lifetime, and if you have somebody, for example, who's diagnosed as a teenager with ITP, they may be okay and able to live life fine with platelets of 20 to 30, and then they fall pregnant, and actually then you do need a higher platelet count for that period of time to deliver. So it is a little bit of a sliding scale, and it's a process in evolution. But as we evolve ITP clinical centres a bit more in the UK, linking into the bigger centres that are used to seeing more patients, have nursing specialist background, etc., that ability to be able to tailor treatment better becomes a bit easier, and we learn a lot more. And in addition to the IWISH study, the UK Patient Support Association were part of the Trapeze study, which was a similar thing around patients' preferences and responses, how they felt in response to receiving a thrombopoietin receptor agonist, whether that was eltrombopag or romiplostim. It wasn't avatrombopag because it was before then. And again, not only fatigue, but anxiety was also a big player in the symptoms. And I think anxiety feeds fatigue too, because you feel, that kind of worry about things and what's my platelet count going to be can be very draining. So I think it's potentially biological complement. I think it's quite complicated. And I know Mervyn is quite keen to actually look at, some studies around psychological interventions to help patients with ITP and see if that improves. Because as Drew rightly said, sometimes the platelet count is really good and patients still feel very tired. So it probably is quite complicated. Does that answer your question? And were there any more questions on fatigue?
Don't you think we're inducing anxiety? If there's a measurable number of something, whether it's hemoglobin or blood pressure or PSA, or platelets, as soon as you go to get a result and it's coming up, like next week I'll see them and I'm going to see my result, people get really stressed by just for a number. If we ease back from that, then we would bring their stress down quite a lot. Don't you think? Do you fixate on the number or not?
I think everybody's different. I think I'm a bit of a numbers girl. I like reassurance. I like to know. I like to have seen it.
But if you feel fine, you've got no bruising. If you feel fine, you've got no bruising, what does it matter?
Are we on a counselling session for me now, Dr. Sample? I think there is a degree of individuality to that, and there's a safety element as well about keeping people well and just preempting if somebody's baseline count is a bit lower. Just reassuring them, seeing them, touching base, giving
Do you
that
think seeing the
physical
platelet count
contact.
saves lives?
It depends. Yes, if
prove
the platelet count is 1, Dr. Craven, somebody's bleeding. Yes, it does.
Really?
But you're quite right. You don't want
Do you
to
feel
over
better?
medicalise. Yeah.
Yeah, but many patients are so stable at a platelet count between 20 and 40,000. And, you know, I don't even bother getting platelet counts in these patients just because I have them call me when there's symptoms. And so if they start having symptoms, they'll automatically go to a blood drawing place to get their counts drawn. But there's and many of my patients, I mean, gee, I'm glad I don't have to get a routine count because I was worried about getting a count and where it was low and then it comes back okay. I think we create an anxiety, but other patients need to monitor closely. People who are bleeding a lot, who have to be readmitted and retreated, those patients need close monitoring. But there are many well babies, as I call them, of any age babies, you know, that do fine by just saying, call me if you're having bleeding.
We looked at, so with the vaccine, Sue was talking about there's a guideline to have a platelet count done 2 to 5 days after your vaccine. And actually, that's not something we did in every patient who's a patient of the Royal London Centre, partly right at the outset for capacity issues, and also it was difficult to get patients into. So actually our approach was to say, there are certain categories, so they'll put some caveats on, but our approach was to say, actually, if your platelet count's normally pretty okay, and you feel fine, let's not worry. And when we went back and looked at all of our patients, the only ones that had run into problems actually had the lower counts at the beginning. They were, and all got symptoms. And it's similar to what Drew was saying, kind of, oh my goodness, you must have a platelet count 5 days after your vaccine. Actually, I'm not sure that, I think that does breed an anxiety for people. And actually, if you just say, look, there's a small chance we think it's, 1 to 2 to 5%. Keep an eye out for the symptoms. We're here if you need us. Pick up the telephone. This is how to do it in an emergency. I would feel that is a more, for me, and it'd be interesting to hear what everyone else thinks, that was our approach. And actually, none of our patients, we didn't miss any issues when we went back and looked at it. So I'd be interested to hear what other people think about that. Right, we have a microphone. Yes, go.
Yeah, it was just on anxiety. And there's a number, a platelet number, that we all need to be able to have minor surgery or a tooth extraction. And that number is in my head. So I will have anxiety, whatever my platelet numbers are, if it's not that. So to manage anxiety, I prefer to be above that. Whether that influences then my fatigue, if I'm a little bit lower, who knows? But that's where I am with my anxiety levels. It was just a bit of input, really.
Thank you. Yeah. Did you want to? You can have mine.
Okay. I wonder if I could come back to the romiplostin situation. We talked about weaning people off romiplostin if the indications are that the level of platelet is stable. I suffer a wee bit of paranoia because I look after my wife and have done so for 8 years with romiplostin, and latterly I've dealt with it exclusively, very little interaction with the hematologist. My problem is simply this, that I do a blood test at day 16, for example, and I can see that the platelet level is at an acceptable level, 200 sometimes, 250, and occasionally trips into 300, 400. So I wait several days before I give her an injection. But over the years, I noticed that if I fail to give her an injection at the right time, her platelets would fall off a precipice. So I find myself with a dilemma. How long can I stretch it out before I give the next?
Well, we developed this drug, and we developed it we did the pharmacologist drug almost 2 decades ago. And I'll say a couple things. One is that this drug is designed to be once a week. And if you make it once every 10 days, every 14 days, you're going to find bigger fluctuations in platelet counts in the vast majority of patients. Number two, what you do today, you'll know 2 weeks from now. So it's very hard to use it's not something, it's not like insulin where you can affect your blood sugar the next day. This is a thing that you do today, 2 weeks later you know what's going to happen. So in general, I don't advise people fine-tuning their dose as long as their platelet count is in a generalized range. And indeed, most patients on Remipilstim, we tell them get their platelet counts once every couple of months if they're on a stable dose. So we didn't bother checking counts on most of our patients. And if you do it, I've got a patient who, and I'll say she's literally crazy. She works in our blood lab and she draws her blood every day. She's on end plate, and Romiplastim has done so for 10 years now. I have almost 10 years of platelet counts, and they vary from day to day. And if you draw them at certain times a day, so you got to be careful of the fluctuations in numbers, and you can't abide by those. Yeah.
I kept graphs of the platelet movement, and it was up and down. The peaks and troughs were just extraordinary.
Yeah, but that's why you got to teach your patients. You want a platelet count range, not an exact number. You read these papers that we publish that the platelet counts are exactly the same as I showed you. That's 100 patients per data point.
That's encouraging, but there is a secondary problem which has caused me concern. I've become a wee bit paranoid about it, in that I've noticed that over the last several years, my wife has developed neuropathy, heavy legs, painful legs, pains in her arm, shoulder in particular, now the hip, and so on. I was aware of the fact that there was a suggestion at one time that Romiplastin, one of the secondary effects of Romiplastin, is damage to the bones, etc. And I'm just wondering, is there any evidence that Romiplastin has that kind of secondary effect?
My blunt answer is no.
Okay.
It has been demonstrated that some patients develop bone marrow, which is inside the bones, not the bones themselves, scarring down, which happens about 5% of patients and is clinically insignificant, but it should not cause bone pain.
Yeah. So neuropathy is not a future.
No, again, I think, unfortunately, neuropathy is a very common age-related, if I may be impolite, age-related problem.
And Drew, similarly, I've not come across
I've
patients.
never experienced that.
No.
But I mean, someone who's slightly older with like girdle discomfort. I'm sorry, I'm being like my age as well. If you get weak shoulders and hips, then you got to think like polymyalgia and other things which come. Not everything is linked. Patients often have a tendency to link everything that happens either to the drug they're on, because that's the drug they're on, or the disease that they have. But it may be completely separate. Sometimes you've got to take a step back.
Yeah, but good to ask. It's always worth checking.
The question I had was regarding blood tests coming back and saying that there's giant platelet size. What does that mean? Does that mean you need less of them because they're bigger? I don't know. Platelet size.
Great question.
I love that question.
I know. I'm going to fire that at Drew because he's an excellent morphologist, and then John. Go on, Drew.
No, I'm going to hand over to my very erudite colleague here, who has a major interest in morphology. Is not my strong point.
Well, again, there's a physiology of platelet production. As your platelet count drops in a disease like ITP, your bone marrow revs up, tries to rev up platelet production, maybe not be as good as it should do, but when you decrease the number of platelets, these cells called megakaryocytes make bigger particles, which are platelets. So as your count drops, you get larger platelets. And when I talk to patients, I'm not really concerned too much about the number as long as they don't bleed. And then I take them to the microscope and I show them their blood smear, and it's got these gigantic platelets, half of which aren't being counted, and the other half are hyperfunctional. So I think right now, if someone comes to me like Dr. Semple, his platelet count's 10,000 ITP, I'll look at his blood smear. If he's got big platelets, I'll realize that half or more are not being counted, and his real platelet substance is actually quite adequate. And I use that as my way to explain to you or John why I'm sending him home and not treating him at a platelet count of 10,000. And because our counts fluctuate, and they fluctuate a lot from this crazy lady I told you about, they do fluctuate a lot from day to day and sometimes hour to hour. You can draw your blood count after running up a flight of stairs. It's maybe 29,000. You relax for 10 hours, it's now down to 14,000. That's a normal fluctuation given how platelets get sequestered in your spleen, other parts of the body. So I don't usually respond just to one blood count. Maybe you do, Vic, here. I mean, I think we ought to recognize that one flower doesn't make spring, and one low blood count does not mean you got to get IVIG.
Yeah, no, I agree entirely with Dave. So when somebody presents with a low platelet count, you always look at the size of the platelets, partly for ITP, partly because if somebody has a lot of very big platelets, there are some inherited platelet disorders that give you huge platelets. So it's partly a diagnostic tool. And as Dave said, the younger platelets tend to be bigger. We are getting slightly better at being able to measure that. It's not as robust a tool yet as we might like it to be, but we can, in some laboratories, can measure what's called the immature platelet fraction, which is that percentage of baby platelets. We've got a handful of patients with quite low platelets very regularly who don't bleed at all, and their immature platelet fraction is about 50%, where a normal immature platelet fraction is about 8% or lower. So we don't understand it well, but there is an element of that being probably a bit protective. Yeah, Drew?
Yeah, I just wanted to ask about platelet size, because if people bleed profusely or they have hemolytic anemia, they pour out lots of young red cells into the peripheral blood, and they're bigger than a mature red cell, right?
Right.
And,
Correct.
And platelets are normally within a defined size. So will an immature platelet or a young platelet, which is larger, given time, will it become the same size as an adult platelet or a mature platelet?
Yeah. This is data from 45 years ago. But what happens, we all make young new platelets every day. And you've got normal platelet count, you make normal new platelets every day. They enter the circulation with a mean platelet volume of about 12.5, which is a little bit at the upper limits of normal. They drop to about 8.5 by day 8 or 9. So normal platelets sort of decrease a bit in size. But as you shorten your lifespan of platelets from 8 days to 1 day to 6 hours, all you have left are the new platelets, which in general are on average much bigger, hyperfunctional, and protect you. And this is why people with ITP at a platelet count of 10,000 will not bleed most of the time, whereas a leukemia patient at 10,000 will need a platelet transfusion.
And that's why you might see ITP patients often may have a slightly different platelet threshold for an intervention, procedure, transfusion or otherwise, because we recognise that the bleeding risk in ITP is actually lower for a lot of patients compared to somebody whose bone marrow isn't working and their low platelet count is because they're not making enough. And those patients those platelets are often not as, it's simplistic terms, but they're not as fresh and sprightly as perhaps patients where bone marrow doesn't work.
And the flip side of that is the orthopedic surgeons don't believe any of this.
Orthopedic surgeons never believe anybody about anything, unless you're an orthopedic surgeon. I'm really sorry.
Thank you. I just wanted to ask, while we're talking about platelets and platelet size, I have anti-phospholipid antibodies, and I was told about my platelets clump. So how does that affect the count? Because nobody's really explained it to me. Does it affect the count?
Well, 1% of all platelet draws in a general population will clump. When you draw blood into a tube, which is a lavender top tube, it lowers the calcium concentration, but there's EDTA in the tube, and that draws the calcium down. When the calcium is low, many patients, 1% of patients, have a preformed usually an antibody that causes the platelets to clump. It may not be related to your antiphospholipid antibody syndrome one tiny bit. Many patients with ITP also have what's called pseudothrombocytopenia or platelet clumping. That also confounds our counting ability, but most modern machines like the Sysmex machines, which I think you got as well here, will flag that. And that's why a good hematologist will have a microscope and look at the blood to make certain that we're not dealing with pseudothrombocytopenia. But again, I wouldn't blame it upon your antiphospholipid antibody syndrome. It's not uncommon in the general population, a bit more common in ITP patients.
Yeah, so in a general haematology clinic, there are often a few referrals for thrombocytopenia that's not a true thrombocytopenia, it's clumping. And I don't know whether your team have ever get your blood count done in a blue top tube. They call it a citrate full blood count. So if you get clumping in EDTA, then you need to have your full blood count done in a blue top citrate tube differently, because then the vast majority that do clump in EDTA don't clump in citrate, although we've got one patient that clumps in both to get an accurate count. It's not very good at giving you the other parameters. It only gives you the platelet for citrate, so it doesn't save you a tube. Sadly, you end up having to have two.
Thanks. I had a question about TPOs. We talked a lot about TPOs today, and my wife was diagnosed 3 years ago, and TPOs were not mentioned as an option then. I'm just wondering what the history is, and are they recommended through the NHS as well? Because in those days it was basically steroids and rituximab.
Drew, over to you on TPOs.
This was 3 years ago. Okay, well that's unusual. We've been using them.
Well, it's the timing probably of the TPOs. You mean up front at the beginning? of her treatment. Yeah, so we.
Obviously, okay.
So maybe a question just around the timing and availability.
Okay. Yeah, the licenses, they have a so-called a license for each one, and we're allowed to use them at a certain point in the disease history. So previously, we were not allowed to use them at the beginning of soon after diagnosis, because the license is not for that, it's for later. However, during the pandemic, we were given free rein to use them from the very beginning. That's unusual, and we call it off-label. It's not what the license says, but we're given a lot of freedom. I think that's probably why she didn't get it initially. But presumably she's had it now. Yeah, she got them now.
So we went down a different route for treatment because she had CLL as well, and the haematologist reckoned it was the CLL that was causing the problem. So she treated the CML with obituzumab, I can never remember, something or other.
Ofatumumab.
And something else. What was it called? Venticlax?
No, bendamustine and ofatumumab, I guess.
No, venetoclax. Thank you. Yes. Yeah. So no, that was the option. But the NHS was basically offering steroids or rituximab.
The license is for primary immune thrombocytopenia, where there's no other disease. If you pick up CLL with ITP, then it's a sort of secondary form of ITP, which would certain commissioners, certain CCGs, or whatever we call them nowadays, will not pay for that indication because it's outside of the licensed approved disease. So that's why. But then it's a difficult area.
Often for secondary ITP, we do usually look to try and manage the wider, whatever the condition is, if we feel ITP is secondary to it, in addition to the ITP. And there are patients we can use TPO-RAs on off-license in a setting, because sometimes combination is needed. But if there are other things potentially driving the ITP, the TPO-RA on its own sometimes actually isn't enough, in my experience. For the more tricky patients with quite severe lupus, rheumatoid and other things, you often do need actually more than one thing to come in. Dave, you wanted to say something?
Yeah, one of the problems we face with secondary ITP due to either lupus or due to CLL is that sometimes the ball's already half rolling down the hill, and treating the CLL or treating the lupus may not affect the underlying autoimmune condition. That's not always the case. Sometimes you have good luck treating both, but oftentimes when we treat CLL, the ITP still persists, and then you go on to the typical ITP therapies at that point. But it's not unreasonable to treat the CLL first, or the hepatitis C, or the HIV, or the lupus.
Yeah.
You triggered another question, actually. Sorry to hog, I do beg your pardon, but as we progress, questions come to mind. My wife has Evans syndrome, and I've spoken about it. And what I found curious, you know how difficult it is to balance the treatment when you have Evans syndrome. I've noticed that since my wife's been on romiplostin, I'm just looking at the last results, her red blood is up at 14.5, near the limit, and her platelets are at 295. Previously, she had to take steroids to control the red blood. We dispensed with those after that horrible experience when she finished up on 120 milligrams of prednisolone, and they were taken away completely. So I'm just wondering, is romiplostin in effect the best treatment for Evans syndrome? Have they actually achieved a cure? Well, not a cure, but control.
Well, again, for those who don't know, Evans syndrome is concurrent antibodies against red cells and against platelets. And oftentimes when the red cell count is low, the platelet count's high because the body's preferentially sacrificing the red cells and the platelets are surviving. Romiplostim should not be affecting the anti-red cell antibody. So basically, people do have remission. Did you receive rituximab as well? Because that's usually where we start with this disease. Because many people can have one disease flare up and then it's in quiescence for years. Then it can. I'm not to say it's going to come back, but I would just be curious to know whether your anti-red cell antibody, called a DAT, is still positive. It sounds like you got your whole spreadsheet there. So
the joy of patient view or whatever it is. While he's looking that up, Drew, so any additional stuff for Evans syndrome?
I agree with Dave. It's a funny condition, Evans. In a way, it's slightly more difficult to treat than ITP And if we use standard ITP treatments, it sometimes doesn't respond as nicely as ITP. I'm not quite sure why that should be. I don't think there's not a lot of research done on Evans, unfortunately. And I'm not even sure we have a registry for Evans or anyone's collecting the data on Evans. There's not really a lot published, is there?
I was just about to say we have our Royal London hemolytic anemia expert. Hold on. Run down.
I just wanted to say something about Evans. I think it's really important that that you refer to an immunologist, because Evans syndrome is often associated with inherited immunodeficiency syndrome, and it's important to rule that out. And the treatment may be actually different if you had an inherited immunodeficiency syndrome.
We're just looking at the...
Oh, that was a...
Yes, I mean, Evans syndrome, I think, is more... You often need immunosuppressive therapy earlier on, and it's an order of magnitude rarer than ITP, isn't it? So there isn't currently an active registry, but Dr. Hill... Dr. Hill...
Well, we're developing one.
Brilliant. And I think Quentin's trying to look at one further, UK. Did you want to say something?
There's a few points come up really. Sorry, there's a few points come up really. I mean, I've had 2 bouts of ITP. The first one was diagnosed in '92, so pre-internet. So
you need to speak a bit closer, I think, to the mic. It needs. Can you just put it a bit closer?
Oh, sorry.
And then they'll...
Did you hear any of that? No.
Just quite close.
So a few points really. So tell me to shut up if I meander on a bit. But I was first diagnosed in '92, and I actually got a remission quite quickly. And I thought, pre-internet, had nowhere to look for any information other than the doctor was giving me. So I thought it was the end of it. Didn't worry. It came back in 2014, and I was super anxious about the score on the door, anxious about everything. And just coming back to the immature platelet fraction, I found that the way to sort of give myself calm about this whole platelet number was so if the platelet count was really low, i.e. under 50, I would ask what the immature platelet fraction was, because I would know in my head that if that was good, i.e. around the 50-ish, I could walk away and think, right, okay, you just need to take a bit of time out this week and recuperate. And that's kind of how I've coped with the anxiety of it. But I think the anxiety doesn't just come from the fatigue. It comes from the brain fog as well. I don't know if other people find that, because most of us have led really active lives, and then you suddenly find that you've got this fog going on, and you can't quite do things, or it's a very, very difficult thing to deal with. And one of the things that annoys me is sometimes hematologists refer to this. You're tired. Do we need to look at something else? Well, no, you don't. My body's having a great big bun fight with itself all the time. And the serotonin isn't getting around my system. So it's just so complex. But I think the anxiety also depends on how that first diagnosis happened. Was it an acute situation, or did it just come up out of nowhere as a part of a routine blood test or something else? But I'm quite interested in what you were saying about the laser therapy. And the
laser light therapy.
Yeah, the laser light therapy. Well, I mean, how far have they got with that? And are they talking about bathing the whole body in that, or do we need to direct it at the spleen? Or how would that happen?
Well, so far we know that in mice you need to irradiate the whole body, but that's just because you can put a whole mouse in front of a 10 nanometer laser, but this therapy has been used for other diseases with phototherapy. So this is a well-described technology which is safe for other conditions of phototherapy. I can't tell any more about what's happening in terms of clinical stuff because we're still working on monkeys. Mm-hmm. So, but I think right now, coming back to your comment about platelet count number, each of you has three issues. One is a fear of bleeding. Number 2, what's my bad or good platelet count? Number 3, how fatigued I am. And for some people, just to hit the 3 balls, fatigue for some people is irrelevant. Many of my patients have no fatigue whatsoever, but others are almost incapacitated by it. Number 2, I try to recalibrate patients fear of platelet counts by saying, hey, you've done fine at a platelet count of X thousand, maybe that's 18,000 or 20,000, your platelets are big, you haven't bled in years or ever bled, let's not focus too much. So I had to try to recalibrate people's number in their head that makes them feel safe. And once I can show that count has been maintained for some time, I then said, let's back off on how often we check your blood counts, to the point that some of my patients at this point will simply just call me if they have any bleeding or bruising or their periods are heavy.
And I think access to healthcare in a timely fashion is one of the most important things, actually, and something that we're finding a bit challenging in the current NHS climate. But I think knowing who to call and when, and that call being answered in a timely fashion, I think is one of my passions.
I might add one other thing. I don't know if it's true here in the UK, but we got in major cities in the United States, you can give a patient a prescription. They go to any blood drawing place and get your platelet count drawn in 30 minutes. So you can walk in any big city and have your platelet count drawn if you have a prescription for it. So we do that for my patients. Then they just walk in if they're concerned. Just get your platelet count checked and call me, as 2 did that already.
Wow, not quite that sophisticated in the UK yet.
But I don't see why it can't happen. It's it's a cheap test, and it's not as if you're doing a cardiac catheterization. It's a pretty fast test.
Yeah, I agree. Okay, any other questions? Yeah, please do. Are you sure?
Just asked my GP's receptionist I might die if I didn't get a blood test during COVID, to get her to book me a blood test.
Yeah, it is. I think I think it is. Yes. But I also think actually that's also the job of the hospitals, isn't it? If you've got these bigger hospitals that have got units that manage patients with rare and complex diseases, then encouraging a cohesive model of outreach and support is actually also quite helpful. I think that's a difficult task, but because I think it is difficult for primary care too. I mean, having to tell them that seems quite dramatic, but it is hard for them because they don't know about it. It's quite specialised, and so I think it is often quite difficult for them. And generally speaking, I mean, geography plays a part as well, but it is, in some ways, I find it easier to use our outreach hubs for phlebotomy rather than a GP, because it comes to me, there's a safety net of authorisation that you can see it because you ordered it, you can action it properly. If it goes to the GP, you don't know how it's been handled, and they fling tubes around and a courier's putting it on the heater of their bus or whatever they're on, and then the platelet count's not what you think it's going to be. So there are also some advantages to trying to use that infrastructure, but different regions work differently. And I suppose in London we're lucky because it's quite dense. Drew, did you want to say something?
No, I just think you say it should be possible. I have to say, within our hospital, rewind 20 years ago, you could come to the day unit, go in, I've got ITP, I think my count may be below. The nurses would say, oh, that's fine, we'll just do a blood count. You can either wait or go home. No, the day unit will not see you. The phlebotomy service, you used to be able to go in, have your blood done. No, not anymore. We have to tell people to book online. And if you haven't got internet access, we're trying to put barriers all the time to make simple things the most complex things. And it really...
Drew gets a bit frustrated in clinic.
It's very frustrating because I have to try and explain
every now and again.
I have nothing to do with this, but it's simple things that would make life so much easier. It just drives me nuts. And these poor souls have to do the phoning, and they can't get through, and they're on hold, and they get totally fed up. And I'm not surprised. I mean, we have some of our own patients here. Do we not? Have you had any trouble with phlebotomy with a... 2 months. 2 months. Okay.
Yeah, it can take...
Easy to book online? Is it easy to book an appointment? No, I bet it's not.
One, you can tell us what we arranges a blood test. It arrives at the surgery. You then wait and try to persuade somebody that you need to have the blood test because you need to make a decision. And on one occasion, I recall, I couldn't get the blood test result for 2 days. For 2 days. And at 3 o'clock in the morning, I got a phone call.
Oh my God, the plates
are
so low.
They said, "Is she bleeding?" And I said, "What?" And I said, "No." So I'm petrified. She said, "Can you get her to hospital?" And I said, "I don't think it's necessary, but if you insist." And then I decided, no, I shan't. I'll just shut on her.
I mean, that's a nightmare for you, but in the long run, at least the system worked and somebody picked up a low platelet count and phoned you about it, even if it was 3 o'clock in the morning. But yeah. Yes, oh gosh.
No, I was just going to say about trying to book a blood test. You do have to book them online, but all you can do is fill in a form requesting it and saying which dates within the next 2 months you might be available. And then they email you back and with a date exactly when you said you couldn't do it. I've tried phoning. I've been number one in the queue for 45 minutes. No one's answered it, which I assume means they're not actually answering the phones. I now walk into the surgery, but unless you threaten to die on them, all they do is offer to fill in the form in front of you on the screen. So you just go through the same loop again. But it can be up to, for a blood test. This is just for a blood test. Drives me absolutely bonkers.
No,
So we have a question over here, actually.
I suspect it's because the GP practices across the UK operate so completely differently. But I have a system where I personally operate, where I self-manage my own ITP situation together with another blood condition I have, which is genetic. Purely and simply, that I have an arrangement whereby, of my own volition, I go to the GP practice every 3 months and have blood tests of one form or another. And I then, at home, on my own computer, evaluate the results. And dependent upon those results, then take necessary action. As a result of that, GPs who don't understand the condition whatsoever don't get involved, and I determine whether there's any need for action.
So I think, yeah, it is, ITP is not a common condition, and I suppose there's a reason why we spend a long time training and researching to know a bit about it, and GPs don't. Right, I'm just working my way down. Right.
Just a bit of information. We have similar problems, and I have not been able to get my results. This is the latest thing. I phone up and they won't give me the results. How do I do this then? You have to make an appointment to see the doctor, who can then give you the result. Well, this is ludicrous because the doctors are busy enough. So I have learned that you can get a link and you can look up, I think you are probably doing, everyone can get a link to the doctor and get the results at home online. But you have to ask your doctor, or I have to get the doctor to set it up for me. But now when I have my blood, which is difficult, I can look them up myself. So this the good way, I think.
Yeah, no, that's great. But we've hidden things from patients for a long, not me, but people have hidden things like, can I see my case notes? No, you can't. They're private. But who are the notes about? They're about me. Why can't I see my notes? And you phone for your result. No, I can't give you a result over the phone. Sorry. But it's your result. I mean, I don't understand that.
There is a bit probably of safety net protection, isn't there? And I think things like My Patient and Patient View and things should hopefully improve that, because for some areas you can download and be able to get them.
Thanks. The system is very patchy across the UK, and of course, for the last 15 years, since what was called ITFIT started, and the government at the time in about 2008 wasted billions trying to digitise the entire UK. But there is now a system called MyGP, which is very variable, but you can actually log into your practice and the results are there. We've had a lot of dealings with Imperial Trust there. Now they also have an IT system where you log in, and within 3 hours of having a blood test taken, all the results are on my mobile. Now, what the doctor can do, they can block out certain tests in case they're likely to worry you. So if they're doing an HIV test and they want to discuss the results, or if they're doing histology where they don't want you to suddenly look and say, oh my God, I've got cancer, obviously they can block those, but all the routine tests are immediately available. But this is entirely patchy throughout the UK and throughout the GP system. But they're trying to get there. It's just like everything in this country relating to almost anything technological is slow, pathetic and patchy.
And how much money, Professor Newland, how much money has been spent by the Department of Health on IT for hospitals? Because hospitals have their IT system and they all run a different system and they don't speak to each other, do they? You can go to a hospital in Wales, we can't see your result. You can go to a hospital at the Homerton, which is a couple of miles from where we are, can't see the result because they use a different system.
Well, they've wasted billions on this. As a very minor example, about 15 years ago, the government as a whole, the NHS as a whole, had an arrangement with Microsoft so that every upgrade was automatically included on all the IT systems in all the hospitals. That idiot Lansley, when he was Secretary of State for Health, decided this should be what individual hospitals should want to do. So what happens, because the hospital has to fund it themselves, they balance. Shall we have a new theatre table, or shall we have a new ventilator in the ITU, or shall we upgrade the IT? The IT is working, let's do that next year, and then next year something else comes up.
The whole point of digitization is so that we can see anyone's results anywhere at the click of a switch or a button. That's how it should work. But instead, it's become so laborious, so impossible to use. No.
In the interests of Dr. Proven's blood pressure, I'm just going to pull this back.
I have a slight B in my body.
I suppose the shared learning is that for some GP practices, you can do a kind of my view or my GP. So it might be worse for those who haven't been able to access results. And I think increasingly for trusts, they are bringing in, I think it's called patient view or my patient. Patient view, yeah. There is a programme to bring in patient view. I think those of you whose trusts use Epic as their system, you can also, and you have that a lot in the States, it's like the premium, you can log in. Those of us that don't use Epic, sadly, you can't, but it's a work in progress. And I guess shared learning, just to holler if people want to find out from others how to access things. We're in the kind of last, I need to put my glasses on to see, last 2 minutes. Were there any other bits that people wanted to ask just about kind of, yeah? Role on artificial intelligence, and we'll all be out of a job. Anything else that anybody else wants to ask about ITP, some of the treatments? Yes, of course.
Just to finish off the session. Sorry. Is there any problem? You did mention, I think, the problem of funding at some point when you were talking. Is there going to be an issue about those of us who are on very expensive drugs?
Yes, funding is always an issue, and the payers are doing their best to stop us getting access to drugs, to keep the drug budget down. And every time a new drug comes onto the market, it hits the radar straight away, high cost drug, and we're scrutinized, and every application is vetted, so it makes life very difficult. It's postcode prescribing as well. Some places you can get them easily, other places you cannot, depending on the authority, whichever authority. We're in Tower Hamlets, we work, and which is actually very generous, even though it's quite a poor borough. But other ones that are wealthy restrict drug, which is, it's a postcode lottery.
Yeah, so there's as the new drugs come, I don't think anyone's going to take anything away. We obviously had an earlier access programme for the TPO-RAs, which we all really, us and the patients, I think, were very grateful for a period of time. And it was a shame when that pulled back, and we have tried to challenge the decision on various different grounds. It's a little bit more complicated because there has been a change in the way that trusts and the local commissioners access money now, whereas before there was the kind of centralised stuff and then stuff paid for by your local primary care group, as it were, the kind of local commissioning group. It's now all lumped together, hospital and commissioning group, and so it's a very different structure. There's then a bigger pot. So there are some changes, but I think in practice for current access that won't make any difference to the TPO-RAs as they are at the moment. I think for the new drugs, they go through whatever process was been before, which is the NICE technology appraisal, and that's really fundamentally about what benefit does it bring and how expensive is that benefit for a few key criteria. So if the companies get their pricing right, then the drug gets through, and if it's quite costly, then it doesn't always get through. But I wouldn't anticipate that the newer agents that you were talking about, BTK inhibition, neonatal FC receptor inhibition, I don't think that we will get an absolute no on those agents. They are effective. The trials are quite positive, particularly the BTK inhibitors. So I think it's unlikely, it probably won't be that they're second line, but I would think they will successfully work their way through the system when the phase 3 trials finish, don't you, Dave? Yeah. Did you want to say something? Was that you having your hand up, Adrian? No, sorry. Any other questions or anything that people wanted to ask? Well, as always, I really enjoy these sessions. It's my favourite one of the day. And we expanded our panel because actually Drew and John were like, can we join too? And we're very lucky to have them. So thank you very much for everybody for engaging. I think pretty much everybody's spoken, so that's really wonderful. And obviously separately come and find us or email the Support Association for any advice. Any final words from Drew, or are they still simmering over his IT dramas?
No, I'm just at the age of being an old grump, generally. It's like, I think it's been a great day and I'm glad to meet everyone, and we are around for a bit.
Yeah.
So ask us any questions.
Oh, there is a Q&A session shortly on the panel. Adrian, let me come down to you and you can tell us who the panel is for that. I'm getting my steps in.
Well, the panel will depend on who remains and who has to go and get a train. But in theory, it'll be a continuation of what we're doing now with 3 or 4 people joining us from upstairs. So this has been a really quite a lively discussion. I suspect some of it will be reprised in the next session. So don't get bored. It'll help, but stay where you are because the others are coming. That depends on who else has to go for a train as well. We're set up for an hour. Whether it lasts for an hour depends on how lively you, the audience, are.
Brilliant. Thank you very much, panel. Thank you.